So today you'll be learning about chest radiographs in neonates, and this is like a hybrid session I'm planning to run. So I'm going to show you an image, and then I would like you to comment on what you see on the image, the findings, give a diagnosis, and then following that image, I'm going to then go through the theory regarding that pathology. I know as radiologists we find theory boring. We want to see more pictures, more images, not text. But I think in neonatal radiographs, it's very important to know the underlying pathophysiology. Because once we have an understanding of the underlying pathophysiology, that will then help us understand that what are the imaging features on the chest radiograph. So in, in neonatology, chest radiograph is a very vital tool. It's used to diagnose respiratory issues, is used as a baseline for antenally diagnosed congenital structural thoracic disease. It's used to assess lines and tubes and as part of the septic screen in a neonate with unclear infection. Next slide, please. What we need to remember is that we are not radiologists. We are clinical radiologists. So with any imaging, we need to have the relevant clinical information for us to then interpret our imaging findings and give a conclusion. And neonatal chest radiograph is no different. So before we try to interpret a chest radiograph, it's important that we have the relevant information on hand. So what is the relevant information that we need for chest radiographs? Let's start with what I find the least helpful, and that's the clinical presentation. Because most of the pathologies we'll be talking about, the neonates present with respiratory distress. So tachypnea, grunting, nasal flaring, costal retractions. So the clinical presentation really doesn't help us to differentiate what the pathology is. So what is the vital information that we need to know? First of all, gestational age. Is it a preterm or is it a term? Because they are pathologies which are exclusive to the preterm neonates, and they are pathologies that are exclusive to the term neonates. Second, when was the onset of symptoms? Was it acute, first hour of life, or was it a delayed onset? And as we'll go through the slides, I'll tell you why it is important to know what is the onset of symptoms. Then, in cases of term neonates, is there any presence of meconium in the amniotic fluid or no? And then the inflammatory markers. Next slide, please. Right, okay. So we start with this slide. So have a look at this slide for a minute. Don't worry about the lines and tubes. Just concentrate on the lungs. And in the chat, describe what you think you see and what the diagnosis might be. So I'll give you a minute, have a look, and give me your impression about the radiograph. Yeah, so it is a premature neonate. Yep, so you all are already experts on the chest radiographs, you're right. So when I'm seeing this radiograph, to me, what is jumping out is that there's nothing focal, there's no focal density. It's just all looks very ill-defined, and you get this impression of dots, like coarse granularities. So this is how I'll describe as hazy granular opacities. I mean, you're right, in textbooks they use the word ground glass, but for me, ground glass I reserve that term for CTs. I don't tend to use ground glass for radiographs. So here I'll say they are hazy granular opacities. Next slide, please. Yep, so this is respiratory distress syndrome, or it's even called as hyaline membrane disease, surfactant deficiency disorder, and it's the most common cause of respiratory distress in preterm infants. Next slide, please. So again, clinical presentation, we are not concerned about that because it's the same. So the risk factors is the prematurity. The more premature the child is, the greater chance of them developing this syndrome. Next, please. So what is the underlying pathophysiology which causes these appearances? So ideally, we have got type 2 pneumocytes that produce surfactant. And what the surfactant does, it reduces the surface tension, and that causes the alveoli to sort of keep the alveoli open during expiration. In premature neonates, they have got immature pneumocytes. So what happens? They have insufficient surfactant that increases the surface tension, and the alveoli collapse during expiration. It doesn't. They don't open up. That reduces the lung compliance to reduce. It makes the lung stiffer. Next, please. So then what we are seeing, what are those diffuse granular opacities then we see on plain radiographs? So those we are seeing is microatelectasis. So those are the collapsed alveoli, what we are seeing. So usually they are bilateral, they are symmetrical, and what we call as white lungs. Low lung volumes are usually useful if if the neonate is not intubated. Once they're intubated, then they can be hyperinflated. And thing to remember is that they are treated with external surfactant. So often on the subsequent radiographs, we might see asymmetrical improvement. So some areas might be well aerated and some might be less well aerated. Next, please. And associated abnormalities are what we get in a premature child. Otherwise, germinal matrix hemorrhage, necrotizing enterocolitis, patent ductus arteriosus, and so on. Next, please. This is another example of again of respiratory distress syndrome, where again we see a bit of background hazy granular opacities. Next, please. So in this child, tell me what else pathology do you see other than the whiteout of the lungs? Is there anything else that's jumping out? Yes, very good. So again, we can see this lucency projecting over the left superior mediastinum. So again, we know that neonates are lying on their back, so they don't get in pneumothorax. Very rarely do we see the lung border. So this is a pneumothorax, again, stiff lungs, non-compliant lungs. We are uh, trying to push in air, and they are prone to get pneumothoraces. So this is a uh, surfactant deficiency which has been complicated by pneumothorax in the left upper lung. Great.
Uh,
Next
uh,
slide.
excuse me, Bilal. Can I suggest something? And this is for everybody who is in the chat. If we can slightly organize the format, when you ask them, uh, just use the word now the chat is open. When
Right.
and give them a few, whatever time they want. Because what happens is that if somebody writes in the chat later on, it jumps up on the image and everybody gets disturbed. So
Right.
if you can say that chat is open for give me your answers, give them a bit of time, and then say, chat stop
All
chat.
right.
Stop chat will be a cue for everybody and for the audience. When stop chat is used, then please don't ask anything. If you have got a question or anything, he is just note it down, and I'm sure he will at a particular moment ask you questions. So you are absolutely fine. Because this is extremely important for this format. Please, I repeat that when somebody puts anything in the chat, it just pop ups on the screen and disturbs everybody. Thank you. So start chat and stop chat, whatever you want to use.
All
Okay,
right.
Bilal.
Thank you. Yeah. Sensibly. Yeah. Great. All right. Next slide, please. All right. Okay. So this is a preterm neonate, had acute respiratory distress at premature. He's a premature neonate born with respiratory distress, was intubated, and now the neonate is 5 days of age, and they have requested a radiograph to look at the lung to see the status of the lungs. So again, tell me, describe first what the findings are, what do you see, and then what do you think the diagnosis is. So start chat. Yep, stop chat. So yep, so yes, most yep. So right. So what, looking at this image, so what strikes out when you're comparing both lungs, that on the right side we see these lucencies. Some of them are round, some are more tubular side, tubular configuration, some are more rounded configuration. Other thing we can see is that the right lung is hyperinflated compared to the left side. Other thing to note is that there's herniation of the right lung towards across the midline towards the left. So this is in keeping with pulmonary interstitial emphysema. Next slide, please. So what is pulmonary interstitial emphysema? It is abnormal location of gas within the pulmonary interstitium and lymphatics. Next slide, please. So in very rare cases, when it's quite extensive, it can cause compression of the lung, vasculature, and subsequently impede ventilation and pulmonary blood flow. But that's very rare. Often, what we do is we find it as an incidental finding on routine chest radiographs. Next, please. So, what is the underlying pathology? Is barotrauma. So, it's almost always seen in premature neonates who are on mechanical ventilation or on CPAP. So, you can imagine that the lungs are very stiff, they're very non compliant, and you're trying to push in air. So, what happens? It causes the alveoli to expand and then rupture. And once it ruptures, then the gas then extends into the interstitium and into the lymphatics. So, what happens with pulmonary interstitial emphysema? It can resolve spontaneously or it can persist chronically, and sometimes it can leak into other spaces and cause pneumomediastinum, pneumopericardium, pneumothorax, and so on. Next, please. So, yeah, on the plain radiographs, again, it can be very focal. It can affect one lobe, it can affect one whole lung, or it can be bilateral. And often the affected segment will be hyperinflated and will be static over multiple radiographs. And the typical appearance is of cystic or linear radiolucencies, which are radiating from the hilum into the periphery. Next, please. So, in order to reduce the risk of pulmonary interstitial emphysema, the neonatologists use a specific type of ventilator settings called high frequency oscillating ventilation. So, what does that mean? So, that means that they give a constant background airway pressure, just enough for the alveoli to remain open, and then in between them, they give short, rapid bursts of breaths, and that just reduces the risk of developing pulmonary interstitial emphysema. Next slide, please. So yet here is another few examples. On the left side, you can see a premature child with surfactant deficiency was intubated. Subsequently, on the right side, when you see the plain radiograph, you can see compare the right and left lung. You can see on the left lung, you can start seeing that these lucencies starting to develop, and you can see a retrocardiac opacity on the left, which is in keeping with a localized pneumothorax. Next slide, please. This is the same child. Again, you can see on the left-hand side, the pulmonary interstitial emphysema is much more established now. We can better appreciate the round tubular lucencies. And then on the right-hand side, on the right-hand image, we can see after a few days, we can see that the pulmonary interstitial emphysema has resolved and there is persistent pneumothorax on the behind the heart. Next slide, please. Here, this is another case of more extensive pulmonary interstitial emphysema. So here you can see it's involving the both lungs. They're hyperinflated, and one of the secondary signs of hyperinflation is you can see that there is flattening uh, of the hemidiaphragm on both sides. And I don't know how well it's projecting, but if you look at the right lung at the apex, you can see the lung border. So here is associated with a right pneumothorax. Next slide, please. All right, okay. So this is a extremely premature child who was intubated at birth, and now he's at 5 weeks of age. So on the chat, just tell me first, describe what are the findings that you see and what you think it is. So chat is open. Okay, chat close. So chat close. So yes, you're right. This is in keeping with bronchopulmonary dysplasia or chronic lung injury of prematurity. Now, some of you have mentioned pneumothorax on the left, but no, there's no pneumothorax here. So I guess what you mean is the lucencies at the bases. So this is one of the manifestations of chronic lung injury of prematurity where you get areas of overinflation. So the asymmetric lucencies that we are seeing on this radiograph is areas of hyperinflation. Because you can still see the lung markings through that lucencies. So that's why it can't be a pneumothorax. With pneumothorax, you shouldn't be seeing any lung markings. And the areas which are less lucent, which are more dense, ill-defined, those are the areas of scarring, of fibrosis. So this is a very typical appearance of bronchopulmonary dysplasia or chronic lung injury of prematurity, where you get areas of fibrosis, ill-defined scarring, and areas of overinflation. So it's important not to overcall the areas of overinflation as pneumothoraces. Next slide, please. So yes, so again, it's what is bronchopulmonary dysplasia? It's just lung changes that develop in neonates after several weeks of prolonged ventilation. And the extreme premature the child is, the more risk of them developing uh, this bronchopulmonary dysplasia. And the specific definition of bronchopulmonary dysplasia is that you have got abnormal chest radiographs, and at the same time, the child needs continuous need of oxygen at 28 days of life or at 36 weeks corrected age. Next slide, please. So what is the underlying pathology? So here the pathology is multifactorial. So there are multiple factors that are going at the same time which are causing these appearances. So first of all, it's a combination of hypoxia. So you've got hypoxic lungs and then oxygen toxicity. You're trying to blow in gas in very weak lungs, in very vulnerable lungs, and that's causing over distension of the airways. They burst, they try to repair themselves, and as part of the repair process, the scarring of the alveoli, there's interstitial fibrosis. At the same time, because all this inflammatory process is taking place, the body is trying to fight it, is producing macrophages, histiocytes, which go into the tracheobrachial tree, into the airways, cause obstruction, air trapping, and hyperinflation. Then you get wall damage, the fluid starts seeping into the interstitium, get pulmonary edema, and over time, this thickening of pulmonary arterioles, the heart has to work harder, and they develop pulmonary hypertension and subsequently cor pulmonale. Next slide, please. So on the plain radiographs, like I said, the typical appearance is what they call bubbly lungs. So bubbly lungs is just a combination of scarring, which is manifested as ill-defined interstitial opacities, and areas of overinflation, which are manifested as areas of lucency. And in the setting of pulmonary hypertension, you can start seeing development of cardiomegaly. Next slide, please. The prognosis is often not really good in the sense that these units often are on long term, they are dependent on oxygen. So they are on long term oxygen as part of this insult to the lungs, airways, they become hypersensitive. They start developing obstructive airway disease, poor growth, failure to thrive, and they get recurrent superimposed infection and recurrent hospitalization. Uh, One I see on the chat say, what's the difference between PI and dysplasia? So pulmonary interstitial emphysema is a reversible process. So it can be seen is usually at a more sort of acute phase. It's because the lungs, like I had explained, that the lungs are stiff, not compliant, and there's damage to the alveoli, and the gas then seeps into the interstitium. But it's a reversible process. It can go back to normal. Whereas in in case of dysplasia, that's a non-reversible. That is a continuous, slow, continuous deterioration of the lung appearances. So that is in pi, it's just gas within the interstitium. In bronchopulmonary dysplasia, there is fibrosis, there's scarring of the lung. So that is the differential. So children on long-term ventilation, they can go from RDS straight to bronchopulmonary dysplasia. They don't necessarily have to have pi. All right. The time frame does matter. Like I said, the longer they're on CPAP or intubated, that means the longer their lungs, they're getting oxygen toxicity, their alveoli are getting more prone to rupture and then repair themselves and fibrosis. Next slide, please. Yeah, so this is another example of chronic lung injury of prematurity. So again, you can see very ill-defined opacities, and you can get some overinflated lungs. Now the tricky bit with neonates with chronic lung injury of prematurity or bronchopulmonary dysplasia is that their radiographs can wax and wane. So on some days their lungs can be relatively clearer, like similar to this. Next day they can start getting mucus plugging, they can get lung collapse. Often these children have patent ductus arteriosus, so they can get pulmonary edema, they can start getting pulmonary hemorrhage, so they can start waxing and waning their plain radiographs. Uh, One is how to tell lungs are hyperflated or not in newborns. That's a really tricky bit because theoretically, when you see the theory bits, there are a lot of things in theory that help you differentiate whether the lungs are hyperinflated or not. But in real life, I find it really tricky to comment on lung volumes. So it's more like subjective. The more you see it, you get a bit of you get a bit of impression, are they inflated or no, but it's very tricky to, for me, one of the signs are maybe if there is flattening of the hemidiaphragms. I think that's one sign to say whether the lungs are hyperinflated. Otherwise, uh, in day-to-day practice, it can be really tricky in these tiny neonates to say whether the lungs are hyperinflated or no. One of the signs is that if you see if there's asymmetrical hyperinflation, is easier because you can see one lung volume is bigger than the other. One of the other signs of hyperinflation could be if there's this lung herniation across the midline towards the other side. Next slide, please. So this is again the same child, and we're going to go through some images over course of weeks and months, right? So on the left side, we can see this is done, I mean, relatively when the child was like within the first few weeks, and we can see that sort of bite out of the both lungs, bit of polyaerated lungs, RDS going on. And then after a few weeks, on the right side, we can see the radiograph done after a few weeks. So after 10 days of life, I don't use the word surfactant deficiency or respiratory distress syndrome. After 10 days, 14 days, I think we have started to come into the territory of evolving lung injury of prematurity or evolving bronchopulmonary dysplasia. So on the right side, we can see that the child has started developing chronic lung injury of prematurity, and now we see this opacity in the right upper zone. So this, like I mentioned before, that these children, these neonates are prone to get mucus plugging, collapse. So this neonate has got right upper lobe collapse, probably secondary to secretions. Is this infection? Is this pneumonia? We can't turn imaging. They'll have to correlate with inflammatory markers. So, like I said, I see a lot of these radiographs, and often it's collapse. We see this collapse, and after a few hours or next day, it will have gone away. So the fact it goes away so quickly on imaging is unlikely to be pneumonia. But if I'm looking at this radiograph, I'll say right upper lobe collapse, probably secondary to secretions. If the inflammatory markers are raised, then yes, superimposed infection is a possibility. But in my experience, more often than not, is the collapse that gives this impression. Look at the heart on these images. Next slide, please. And this is the same child after a few months. And look at the heart now. So this child has, because over time he's developed pulmonary hypertension, and as a result, he's developed cor pulmonale, and now we can see that the heart, we can appreciate that the heart is quite enlarged. So now this child there'll be a risk of him developing pulmonary edema, secretions, and it will be quite a tricky child to get on top of. Next slide, please. All right, okay. So this is a term child and acute presented with respiratory distress on birth. So he's a term child, and chat open. Describe what you see and what you think it might be. All right, chat closed. So when I look at this radiograph, if I've been given this information, term baby, respiratory distress, and I see this radiograph, yes, most of you are completely right. So what we see, so what's like in when we looked at the radiograph for the surfactant deficiency, what was the predominant feature? A lot of dots. Here was the predominant feature, a lot of lines, fine, sharp lines, permeating from the hilum to the periphery. And like someone had rightly noted, we can see often we can often we do see fluid in the horizontal fissure even in asymptomatic neonates, but here we can see it's quite thickened. So there is fluid in the horizontal fissure, and we see this perihilar fine lines going across from the hilum into the periphery. So this is in keeping with transient tachypnea of the newborn or retained fluid like TTN. Next slide, please. So yes, so it is called wet lung disease. Is a benign, self-limited condition which presents shortly after birth and often seen in term or near-term neonates. Next, please. Again, the hallmark of this condition is that the presentation is very similar, and the hallmark is that it usually resolves within 48 to 72 hours. Next, please. So, what is the underlying pathology? So, there are two, uh, two conditions going side by side. So, one is lack of clearance of the fetal lung fluid, and the other is excess fluid. So, the maternal prostaglandins that are passed to the neonate, what they do, they help in dilating the pulmonary lymphatics. When the pulmonary lymphatics are dilated, they absorb the excess fluid. Whenever there's imbalance of the prostaglandins, so like in maternal diabetes, asthma, or male newborns, then that reduces the risk of that reduces the concentration of prostaglandins, the lymphatics don't dilate, and the excess fluid is not absorbed. The other is that in a vaginal delivery, we get the mechanical squeeze. So the neonate thorax is compressed and the excessive fluid is squeezed out. Whereas in C-section, there is absence of the thoracic compression. So they are at a higher risk of developing uh, the TTN. Next slide, please. Yes, on the plain radiograph, the typical appearance is what we see in adults like pulmonary edema. So we see a lot of streakiness, a lot of fine lines going from the periphery to the from the hilar to the periphery. Pleural effusions may be present. If they are present, they are usually small. And the radiograph, it it follows the course of the clinical presentation. So that means that there's improvement in both, not only in the clinical status of the child, but even in the appearance of the chest radiographs within 48 to 72 hours. Next, please. So the treatment is just symptomatic close monitoring. Sometimes it can be difficult to differentiate neonatal pneumonia sepsis from TTN. So often here they start neonates on antibiotics, initially send their CRP inflammatory markers. If they come back normal, they stop it and they just treat it as TTN. Next, please. So yeah, so here this is another example. And again, you can see sort of blurring of the perihilar haziness is sort of very ill-defined, it's not sharp. And again, you get this impression that they are sort of these sort of lines that are radiating from the hilum into the periphery. Next slide, please. All right, okay. So this is another term, neonate, but I don't want to give too much of clinical information, because if I give the clinical information, you will get to the diagnosis. So instead of the diagnosis, I just want you to describe me the findings. What do you see on this radiograph? So chat open. All right, chat closed. So some of you have called it as granular opacities. To me, granular looks more like round. Here it's more like lines rather than round. So these are like course of interstitial lines rather than round, like rounded granular opacities. And here I'll just say coarse interstitial markings or coarse streaky opacities extending from the hilum to the periphery. And yes, I didn't give the information that there was meconium in the amniotic fluid. So this is uh, meconium aspiration syndrome. And if we go back and think how TTN looked, TTN was very similar in the sense you get a lot of these lines radiating from the hilum to the periphery. But in TTN, if you remember, the lines were very sharp, they were very fine. Here they look very coarse. And like some of you have said, like ropey, like that's how it is, like rope like, very coarse, very thickened, and they are on both sides. So this is meconium aspiration pneumonitis. Next slide, please. Yep. So again, this is meconium aspiration syndrome, and often it is because of intrapartum or intrauterine aspiration of meconium in the term or post-term uh, infants. Next slide, please. So again, the most important clinical information here is that was the meconium stain amniotic fluid at birth or no? So then that will uh, help you then reach the diagnosis. Next slide, please. So when the fetus is within the amniotic sac, the amniotic fluid is clear, they're often swallowing the amniotic fluid, the fetuses. So if any kind of insult, like placental insufficiency, maternal hypertension, preeclampsia, cocaine abuse, infection, it what it does, it causes the fetus as a result, as an insult, it causes the fetus to pass meconium within the amniotic sac. And when it does that, it then swallows the meconium and aspirates it. Next slide, please. And meconium is a very dangerous cocktail. It's a very nasty cocktail of mucus, gastrointestinal secretions, bile source. It's very irritant to the line, to the airways, alveoli, and then it causes obstruction, and subsequently it causes chemical pneumonitis. Next line, please. And again, the lungs, the typical appearance is a hyperinflated lungs, and that's because of obstruction to the distal small airways and gas trapping. It can be asymmetric, patchy, multifocal. In books, they call it like rope-like. Sometimes you can get pneumothorax or pneumomeliastinum because again the lungs are because the pneumonitis they are very stiff, they are sore, they lose their compliance, and they are more vulnerable to barotrauma. Next slide, please. Again, mortality can be quite high in these neonates, and treatment is often supportive, like respiratory support. They might CPAP, intubation. They need quite uh, quite regular suction of the secretions, antibiotics, and in very rare cases, they might need to go to ECMO. Next slide, please. So again, this is another case of meconium aspiration pneumonitis. So again, you can see very coarse, sort of both the lungs are very coarse opacities on both lungs. But again, on imaging, different pathologies can look the same, and going forward, other pathologies can also give this appearance. But again, it's the clinical information that's the most important. So if there is meconium in the liquor, when I see these appearances like this coarse opacity is bilateral, meconium aspiration pneumonitis would be my top differential. Next slide, please. So this is a bit of tricky one. So this is a term baby. Uh, he was vaginal delivery, no meconium at birth, but the onset, and he was okay when there was no symptoms at birth. The onset of symptoms, respiratory distress, started at 6 weeks of age, 6 hours of age. So respiratory distress started at 6 hours of age, term baby, vaginal delivery, no meconium. What are you thinking? What are your thoughts? Chat open. All right, okay. Chat closed. So some people have said biden mediastinum. So again, need to remember that in children, the cardiothymic counter, the thymus can be quite relatively bigger compared to the heart, strangling the heart. So important not to call mediastinal widening just on one radiograph. This is just the thymus. Someone said shaggy left heart border, which I see what you mean. But need to remember that when newborns, they'll always have a bit of lung congestion, a bit of central congestion. It's not abnormal. It's not unusual to have that. So to me, if I just look at this radiograph on its own, to me, I would say it's more or less normal. Because again, some of has said some streaky opacities. Again, something to remember in newborns, there will always be some central congestion, but the streaky opacities are not that extensive. They're not going to the periphery like we saw in TTN, or they're not that coarse that we see in meconium aspiration pneumonitis. So yes, this next slide, please. So yes, so this is neonatal pneumonia, or it is interchangeable with neonatal sepsis, neonatal infection. And when we talk about pneumonia in adults, we often think of a density, opacity, which we see on radiographs, but in neonates, that's not always the case. Next slide, please. So again, the risk factors are rupture of membranes more than 6 hours before delivery, or prolonged complicated uh, labor. Next slide, please. Again, the respiratory distress can be of various degrees. They can be tracheal aspirates, apnea. Again, they don't only have to be hyperthermic, they can be even hypothermic, lethargic, poor feeding. But again, more than the clinical presentation, I think is when did the clinical presentation start? So the pathologies we have discussed so far, RDS, uh, TTN, meconium aspiration syndrome, they often are very acute. They are present at birth, or at least at the first hour of birth. But if the symptoms start later on, 4 hours, 6 hours, hours after birth, then always think of neonatal infection, sepsis. Next slide, please. Sorry, someone has put what findings was on the previous chest X-ray for infection. I'll come to that. All right, just bear with me. So pathology it can be intrauterine spread of infection. It could be intrapartum, so like the neonate has aspirated infected amniotic fluid after prolonged rupture of membranes, and often the pathogens that are involved are often streptococci, followed by Staphylococcus, and rarely they can be atypical like E. coli, Klebsiella, and Proteus. Next slide, please. So this is the important bit that yes, if we see dense space opacities, a bronchogram, then that's easy to say yes, it's infection. But what we have to remember that in neonatal infection sepsis, the images can be very varied. You can get a normal chest radiograph. You can get patchy reticular infiltrates that you see in meconium aspiration pneumonitis. You can get perihilar streakiness, which you can see in TTN. You can get hazy granular opacity, which you see in RDS. So it gets complicated. So that's why here the clinical information discussion with the neurologist becomes very important. Because The question, one audience member put the question, what findings were on the previous chest radiograph for infection? No findings. It was normal. So if you just show me the radiograph, I'll say normal. But if you tell me that, look, the symptoms started at 6 hours of age, I'll say, in that case, consider infection, because in neonatal infection, chest radiograph can be normal. What are the inflammatory markers like? So it's important to know the history as what was the onset of symptoms and what are the inflammatory markers showing. Next slide, please. Again, the treatment is again broad spectrum intravenous antibiotics. Often they can get tracheal aspirates, blood cultures, send them for culture and sensitivity, and it is supportive. Next slide, please. So yeah, so this is the one I showed you before, the initial one, which I thought was normal. So again, now that I see this, so if I see this radiograph, I will report it as, look, there's no focal consolidation, no pleural effusion, but the fact that the symptoms started at 6 hours of age, please consider neonatal infection, sepsis, because chest radiograph can be normal in the setting of neonatal sepsis. Next slide, please. Again, this is polyaerated lungs with granular opacities which we see in suffering deficiency. But if I see this radiograph, okay, I'll see this radiograph, I'll say, yeah, the lungs look polyaerated. I can see some granular opacities, looks like RDS. But then I see it's a term baby. Then I should start thinking that in a term baby, they shouldn't get surfactant deficiency. They shouldn't get RDS. So could this be infection in the BSC? So again, something to then flag it up to your neonatology colleagues that, look, appearances are of granular opacity, but in this term baby, RDS is unlikely, so please consider infection. Next slide, please. So again, this is what we saw in meconium aspiration pneumonitis. I showed you this radiograph. So again, I see this radiograph. I say, yes, there's this very coarse, this is a term baby or a term neonate. A lot of coarse opacities, bilateral. Okay, in a term neonate, we are thinking of TTN. Okay, doesn't look like TTN because they're not sharp, fine interpretation lines. They look very coarse. I think this is meconium aspiration pneumonitis. But then I look at the request. It says no meconium in the amniotic fluid. Then in that case, I should start thinking that, well, I thought this was meconium aspiration pneumonitis, it looks like, but there's no meconium in the amniotic fluid. Then it can't be meconium aspiration pneumonitis. Then I'll flag it up that these appearances are most likely in keeping with neonatal infection sepsis. So that's just trying to think that you have to look. That's why you have to just, it's not like one size fits all. So this pathology that we are seeing can be a few things. You have to see what's the gestation age, what's the meconium, what's the inflammatory markers, and then you have to interpret what you are seeing on the image. Next slide, please. Right, okay, so just in a nutshell, so medical respiratory distress in the newborn. So just a few pathologies that we see in them. So again, important thing is, what is the gestational age? Preterm or term postterm? If it's the preterm, then the most likely cause is respiratory distress syndrome. It can go two ways. With barotrauma, you can get pulmonary interstitial emphysema, and with time, you can get chronic lung injury of prematurity. If it's a term baby, then the pathologies that are exclusive to the term or post-term are transient tachypnea of the newborn, meconium aspiration syndrome, and neonatal pneumonia and sepsis. So again, it's very important to know the gestation age, and then what are the other important clinical information together with the gestation age will then help you interpret the features that you are seeing on the plain radiographs. Uh, I think one audience again put this question: how do you assess low, normal, or hyperinflated lung volumes in neonates? Again, I brought this up before that in day-to-day practice in neonates when they're so tiny, small cavities, I really find very tricky in assessing whether it's low volume or hyperinflated lungs. It can be very tricky. But again, just repeating it, the signs I look for hyperinflation is if there's flattening of the hemidiaphragms or if there is herniation of one side of the herniated lung across the midline towards the other side. All right, okay, next slide, please. So now that we have gone through the causes of respiratory distress and what can be the sequela of those pathologies, now let's try to look at this radiograph and try to get at the bottom of what this might be. All right, okay. So I'll go to two scenarios. So first scenario is okay. We see this chest radiograph. All right, we see that the lungs are poorly aerated. Right, we don't see much of like aerated lungs. A bit of aerated lungs here. We see some opacity in the right lower zone. We see some ill-defined opacities in the left upper zone. We have lost the left heart border. So if I tell you that this is a preterm neonate, so what is your thinking now? In a preterm neonate, where can you see these findings? So chat open. I'll give you a minute. Think over it. That in a preterm neonate, you're seeing these images. What are your thoughts? So chat is open. So this is a preterm neonate. All right. Okay. Chat closed. So I'll just go through some answers and give you. So someone has it's like they said RDS complicated. You just have to be a bit more specific. What do you mean by RDS complicated? By what? Complicated by pneumothorax, complicated by pulmonary interstitial emphysema. So you just have to be a bit more specific, right? One person has put pulmonary interstitial emphysema. No, it doesn't look like pulmonary interstitial emphysema because if you remember, pulmonary interstitial emphysema, you get hyperinflated lungs and you get this round tubular lucencies. Here we don't see that lucencies, that round lucencies, so it's not typical of pulmonary interstitial emphysema. Someone has said post-suffocant complication. Again, I don't know what you mean by post-suffocant complication. People have put RDS treated with suffocant, RDS and infection. Looking at this, I think we have gone too far from RDS in the sense that if you remember with RDS, you should see that fine granular opacities. Here we don't see that fine granular opacities. Here we see the coarse, very coarsening multifocal opacities. Someone has put neonatal pneumonia. Again, if you remember, neonatal pneumonia is more is is something I would think more in a term or post-term child rather than a preterm. It's not saying that preterms can't get infection, but as a term neonatal pneumonia, for when I talk about preterm, I'll keep that at my bottom of my differential. Someone has said asymmetric distribution of surfactant. Again, with asymmetric distribution of surfactant, what happens that you should still see areas of granular opacities which are not aerated, but here again I don't see granular opacities. Here I see very coarse multifocal opacities. So this is, someone has rightly said, chronic lung injury. So this is a child who was preterm and over months has now these changes can be. I'm not saying this is what it is, but something to think about in a preterm baby, preterm neonate. Few months down the line, if you see this, my initial impression was that what we are seeing are changes of chronic lung injury of prematurity, and yes, they can get superimposed secretions, they can get superimposed infection. Right? Okay. Right. Now, going to another scenario. Now you see this radiograph in front of you, right? Okay. And the clinical history. And if I tell you that this is a term baby, all right, term neonate, you see this radiograph, tell me what are your thoughts, what's going in your head, how are you going to interpret it, all right? So chat is open now. So we are now saying that this is a term baby, and have a look. Give me what your thoughts are on the chat. Chat closed. Good. Yes. So again, all there's no wrong answer. All are right questions. All are right answers. Again, it depends on the scenario, right? Okay. So I see this radiograph. All right. Term neonate. So then I'm thinking in a term neonate, what are the pathologies that are exclusive to term neonate, right? TTN. Does this look like TTN? Do we see that sharp, fine lines extending from the hilar into the periphery? No, it doesn't look like that. So I've excluded TTN, right? Okay. Now what am I left with? I'm left with meconium aspiration pneumonitis or neonatal pneumonia. So what is the next important information I need to know to differentiate between those two? Chat open, right? Chat closed. Good. So the next important question I need to know, was there meconium in the amniotic fluid or no? So if the clinical information says yes, there was meconium in the amniotic fluid, then my top differential would be meconium aspiration pneumonitis, right? But if the clinical information says no meconium in amniotic fluid, or when I speak to my neonatology colleague, I'll ask them, was there any meconium in the amniotic fluid? And they say no, then my top differential would be neonatal pneumonia. So that's how you try to dig out what it might be looking at the clinical information. And this turned out to be meconium aspiration pneumonitis. Turned out to be in the sense, of course, no one knows for sure, but the history was term baby respiratory distress at birth and meconium seen in the amniotic fluid. So with that history, I will keep meconium aspiration pneumonitis as my top differential. All right. So again, it's just trying to think of what are the pathologies that are specific to the different gestational age and what is the information that you need to pry out from the from your colleagues. Can it be both? I mean, the thing is, as a radiologist, I try not to give too many differentials. You can't say it can be this, it can be that, it can be this. No. So why not? It can still be both. But what I just try to keep it simple. So, like I said, I'll say, because when you think of pneumonitis, meconium aspiration pneumonitis, it's more like an inflammatory process. It's not like bacterial infection. It's more like an inflammatory process. So it's more like they're going to treat it supportively, give the lungs some rest, do suction. Yes, it's infection, then they start them on antibiotics. So, like I said, I tried not to give too many differentials where I can help it. So here, if there's meconium in the amniotic fluid, so I'll say appearances are most in keeping with meconium aspiration pneumonitis. Yes, if the inflammatory markers are raised, then there is a possibility that this child has now got superimposed infection and they will start them on antibiotics. But on imaging, like I said, different pathologies will look the same, and you have to give what do you think is the most likely diagnosis depending on the clinical information you have been given. All right. Okay. So next slide, please. All right. So now we come to another. So we are out of the medical distress diseases in neonates, and now we are coming to the structural thoracic abnormalities in neonates. So have a look at this radiograph. Term baby, vaginal delivery, respiratory distress. So tell me what you see. Describe what you see and what you think it is. The chat's open. All right, chat closed. So yeah, so there is two. So few people have said congenital diaphragmatic hernia, and some have said CPAM. So someone has said one was. Uh, Someone had said, give me a second, let me go um, to the chat. I think someone had put bowel loops in the, again, right, okay. So looking at this radiograph, okay, what do we see? So again, don't worry about the lines and tubes. Uh, just looking at the lungs. So describe it. First, we try to describe what we are seeing, right? Okay. So what we are seeing are these rounded lucencies in the right lower zone, right? Rounded lucencies in the right lower zone. The left hemidiaphragm is obscured. The lung, the right upper zone lung is squished, is compressed, and we can see that this mediastinal shift towards the right side. We can see the heart cardiothomic outline on the right. So lucencies and and mediastinal shift. So both answers can be correct. Congenital diaphragmatic hernia and CPAM. So you are in the meeting, you are in the neonatology ward, you look at this radiograph, you tell your neonatologist colleague, look, this can be bowel loops, which we see in CDH, or this can be cyst, which we see in CPAM. So your neonatologist tells us, please, can you give us a definite answer? Tell us what it is, because then we have to treat the child accordingly. So I open the question to the floor. If you get what can you do next to help you differentiate whether this is CPAM or this is bowel loops? Chat open. All right, chat closed. Going through some questions. I'll just go through some answers. So cross-sectional imaging is a no-no, right? Because you've got this neonate respiratory distress, tiny. Often I find that in tiny neonates, cross-sectional imaging I find useless because their lungs cavity are so tiny or squished. It's really difficult to interpret the findings that you see. Again, upper GI contrast study, again, no. Because if this was, how will that help you? Because yes, you will see if the stomach has not herniated, you see gas, you see contrast going into the stomach, into the duodenum, but are you any wiser whether are you seeing bowel loops or this is CPAP? No. So I agree with majority of you have said ultrasound, and I agree that's what we would do. It's easy, accessible, quick, without moving the neonate too much, without distressing them too much at the bedside. You can very easily do it. Put a probe on the left hand side. If you see in the thorax, if you see peristaltic loops of bowel, then it is CDH. If they are static, it is CPAP. All right. Next slide, please. Yeah, so this turned out to be congenital diaphragmatic hernia, and as the name suggests, it's herniation of abdominal contents into the thorax. Next slide, please. So often this is detected on antenatal ultrasounds. So the features on antenatal ultrasound that should raise the suspicion of CDH is cardiomediastinal shift to one side, not able to see a normal stomach bubble, or absent bowel loops in the abdomen, intrathoracic herniation of the liver, and or peristaltic bowel movements in the chest. And often, like I said, they are diagnosed antenatally. So often the neonatologists are aware of the neonate having CDH, but often you can get hidden pregnancies or unknown pregnancies. The women have not had their antenatal care, so they might not have had ultrasounds. So in that case, the child can present with respiratory distress, cyanosis. There'll be decreased breath sounds on the affected side. The heart sounds might be displaced, and there'll be scaphoid abdomen. So the abdomen will be displaced, will be shallow, will be depressed because the bowel loops are in the chest, not in the abdomen. So one question is, sorry, what's the answer? The answer is CDH, congenital diaphragmatic hernia. One has said hernia with gastric bubble in place. Well, that's not unusual because maybe the stomach has not herniated. Maybe just the bowel loops that's herniated. Next slide, please. Again, this classification, there's Bogdelic and Bogagne. So Bogdelic is the most common one. It's often on the left side, posterolateral, and often they're quite large and they're associated with poorer outcomes, and they present quite earlier. Bogagne are often found incidentally. They're less common, usually on the right side anteriorly. If there is herniation, it is small, and they may present later on in life with recurrent chest infections, GI symptoms, but most often they're just picked up incidentally when we are doing cross-sectional imaging for some other pathology. Next slide, please. So the primary complication in CDH is pulmonary hypoplasia on the affected side, and that is the most common cause of mortality in neonates because the bowels take up all the thorax. It doesn't give the lung a chance to develop, and that causes hypoplasia, hypoxia, and in some children, mortality. Next slide, please. Again, on the radiograph, we'll see a obscuration of the diaphragm. It will be very indistinct. Often, because the Bogdelic hernias are most common, so often it will be the left side. And again, something to remember that initially at birth, the bowel loops are collapsed. They don't have gas within it. So CDH may appear as an opacity, as a solid appearing density within the thorax. And only shortly after birth, when they start taking in breaths, when the gas starts going through the stomach, small bowel, and the bowel starts filling with air, then you get that typical lucencies in the lungs. But remember that it can even initially present as dense opacity. And other associated features would be deviation of the mediastinum and deviation of the lines toward the contralateral side. Next slide, please. Again, they are associated with malrotation, neural tube defects, congenital cardiac anomalies. So it's important that you highlight that to the neonatologist so that the neonates can be screened for these associations. Next slide, please. This is again more sort of more conventional appearance of congenital diaphragmatic hernia. So here you can see a lot of structures that look like bowel loops, uh, which are occupying majority of the left hemithorax. We can see this hypoplastic lung. You can see how the lung is collapsed here, not collapsed, sorry, compressed, not given a chance to grow. And we can see that there's mediastinal shift towards the left side. And this is the same child post-surgery. And now post-surgery, we can see that the diaphragm is more uh, distinct, and we can see that now there's gas within the pleural space. Now, when we see gas within the pleural space, we say pneumothorax. But I won't call this pneumothorax because when you say someone pneumothorax, they think, oh, it's more acute, more pathological. But this is not pathological. This is what expected appearance in a child with CDH repair. Because just imagine you've got this whole thorax which is filled with bowel loops and very small uh, lung. So when we push down the bowel loops, we've got all this space lying in the thorax. So the lung won't go and occupy the whole thorax instantly. It will take weeks, even months, for the lung to hyperinflate and go and occupy the thorax. So it's not unusual to get gas within the pleural space within the first few days of post surgery. So here I'll say, I won't call it pneumothorax, I'll say there is post surgical gas within the pleural space on the left side. Next slide, please. All right, okay, so this is another neonate. So this is a term neonate, vaginal delivery, no meconium in the amniotic fluid, and inflammatory markers are not raised. So he just came with some respiratory distress. No. So looking at the radiograph, is it normal, or if there's anything abnormal, can you try to see what's abnormal? Can you appreciate it? Chat open, please. Chat closed. Yep, yep. You guys. Yep. Chat closed. You guys are clever. I mean, I don't know. I don't think you needed this session. Yeah, you're right. Uh, so comparing the initially it might be tricky, but you guys picked it up very well, which is good. That if you compare both lungs, if you compare the left upper lobe, you can see that there's more volume there. It just looks a bit more bigger, more volume in that side. And compared to the left lower zone, right lung is a bit more lucent. So yes, this is what congenital lobar overinflation. Next slide, please. And this is the same child after a few hours, and here you can better see the interface between the lucid hyperinflated lung and the compressed lower zone, low low on the left side. And then you can see this mediastinal shift on the left or towards the right. So initially, because of the lymphatic fluid, it can be difficult to appreciate its lucency, but after a few hours, once the child starts taking in breath, then you can see this, can better appreciate the overinflation. Next slide, please. Yeah, so this is congenital lobar overinflation. In the past, it was called congenital lobar emphysema. It is a syndrome of lobar air trapping, progressive hyperinflation of a lobe. It has nothing to do with pulmonary interstitial emphysema. This is a different entity. And it often only affects one lobe, the left upper lobe being the most common. Next slide, please. Again, it's respiratory distress, commonly in the neonatal period, and it can even occur, it doesn't have to be acute. These children, these neonates can present as recurrent chest infections over time. Next slide, please. Again, no one actually knows the underlying pathophysiology, but there's a hypothesis that maybe it's to do with disturbance in the bronchial cartilage. The bronchial cartilage might be absent, might be hypoplastic, dysplastic. So then that causes it to collapse during expiration. And because of the collapse, there's air trapping. And we get like a ball valve obstruction. So that means on inspiration, they're able to inspire air, gas goes into the alveoli, but when they expire, because of the collapsed airways, not all of the gas is able to escape and keeps collecting within the alveoli, and then you get this overinflation. Next slide, please. So again, it might not be appreciated on the initial imaging because of the retained fluid, distended lymphatics, but over time, you can better appreciate the hypolucent lung segment with this hyperinflation, oligemia, and they can be a mediastinal shift to the other side, or there can be herniation of the hyperinflated lobe to the other side. Next slide, please. And again, yes, they are associated with congenital cardiac anomalies, septal defects, PDA. Again, so it's important to screen the neonates for that. And yes, these children will subsequently need CTs when they're a bit older, again to confirm the diagnosis, to evaluate the tracheobrachial tree, mediastinal structures, and rule out any other abnormalities. And the treatment really depends on the clinical picture, clinical status, because if the child is relatively well, they just monitor it, wait and watch. But if the child has recurrent chest infections, then they'll think of surgical resection where they remove the whole lobe, so lobectomy. Next slide, please. So this was the child's CT chest. So here we can again see that hyperinflated left upper lobe, and we can see oligemia. So you can see reduced pulmonary markings in that lung. We can see that how the left lower lobe is compressed because of the mass effect. So this is how this child's CLO looked on the cross-sectional imaging. Next slide, please. I think that's the end of my presentation. So guys, I apologize for the